Hello everyone. For today's video, we will discuss a topic that is often overlooked by beginning researchers, but is absolutely essential for producing credible and trustworthy research findings. Our lesson is entitled Threats to Construct Validity and Statistical Conclusion Validity. Throughout your nursing education, you've learned how to formulate research questions, review the literature, choose an appropriate research design, collect data, and perform statistical analysis. However, even when researchers carefully complete all these steps, their study can still produce misleading conclusions if they fail to consider issues related to validity. Imagine reading a published nursing study that claims a new intervention significantly reduces patient anxiety. Before accepting that conclusion, we should ask two important questions. First, did the researchers actually measure anxiety accurately? Second, did they analyze the data appropriately to support their conclusion? If the answer to either question is no, then the study's conclusions may not be trustworthy, regardless of how sophisticated the statistical analysis appears. As future nurses, many of you will become lifelong consumers of research. Every day in clinical practice, you will encounter evidence that guides patient care, nursing education, healthcare management, and public health policies. Your ability to critically evaluate that evidence is just as important as your ability to conduct research. Today's lecture will help you develop that critical perspective. Now, let's begin by examining what we expect to achieve by the end of today's lesson. By the end of today's session, you should be able to accomplish six important learning objectives. First, you should be able to explain what construct validity and statistical conclusion validity mean. These two concepts are related, but they address different aspects of research quality. Second, you should be able to differentiate construct validity from other types of validity that we've already discussed, such as internal validity and external validity. Remember that each type of validity answers a different question about the quality of a study. Third, you'll learn to identify common threats to construct validity. These are problems that occur when researchers fail to measure the concepts they actually intend to study. First, you'll learn about the threats to statistical conclusion validity. These occur when inappropriate statistical analysis lead researchers to incorrect conclusions. Fifth, we'll apply these concepts to actual research scenarios rather than simply memorizing definitions. You'll practice identifying validity threats in realistic nursing research situations. Finally, you'll be able to recommend practical strategies to minimize these threats. Understanding the problems is important, but knowing how to prevent them is what makes you better researcher. So as we go through today's lecture, I encourage you to think critically about the research studies you've already read. Ask yourself, could any of these threats be present in this study? So developing that habit will greatly improve your ability to evaluate scientific evidence. Before we proceed, let me ask you, when you hear the word validity, what comes to your mind? What does it mean for a research study to be valid? Now that you know your objectives, let's begin with a simple scenario that illustrates why these concepts are so important. So far, we've discussed the objectives of today's lesson. Now, let's begin by asking a very simple question. What makes a research study trustworthy? Many people believe that once researchers have collected data, entering it into SPSS and obtained a statistically significant p-value, their study is already valid. But is that really true? The answer is no. Research is much more than collecting numbers and performing statistical tests. Good research Good research requires us to ask whether we measured the right thing and whether we analyze the data correctly. Let's imagine a simple nursing education study. Suppose a researcher develops a new teaching strategy for nursing students. After implementing the strategy for one semester, the researcher concludes that it improves students' critical thinking skills. At first glance, that sounds like an excellent finding. As educators, we might even be tempted to adopt this new teaching strategy in our classrooms. But before accepting that conclusion, we need to pause and ask two very important questions. First, did the researcher actually measure critical thinking? Perhaps the researcher simply administered a multiple choice examination that measured factual knowledge instead of critical thinking. If that's the case, then we honestly conclude that critical thinking improved. Can we conclude that critical thinking improved? Probably not. The study have measured knowledge, not critical thinking. This question relates to what we call construct validity. Construct validity asks, did we truly measure the concept we intended to measure? Now, let's consider the second question. Are the statistical analysis sufficient to support that conclusion? Even if the researcher measured critical thinking appropriately, this important question remains. Were the statistical analysis appropriate? Was the sample size large enough? Did the researcher choose the correct statistical test? Were the assumptions of the statistical test satisfied? If not, the conclusion itself may be misleading even if the measurements were accurate. Now, this second question concerns statistical conclusion validity. It asks, do the data actually support the conclusion being made? Notice that these are two completely different questions. The other one focuses on measurement, while the other focuses on analysis. Both are equally important. If the researchers fail to address either one, they risk producing misleading findings. Now imagine the consequences. An ineffective intervention might be recommended for patients. Nursing educators may adopt ineffective teaching methods. Hospitals may invest resources in programs that don't actually work. Even healthcare policies may be based on flawed evidence. That is why validity is not simply an academic concept. It directly affects patient care and evidence-based practice. So as future nurses, one of your responsibilities is not only to conduct research, but also to critically evaluate research before applying it in clinical practice. So let me ask you a question. Suppose a researcher claims that a new simulation laboratory improves students' clinical competence. What would be your first question? Would you ask whether the simulation actually measured clinical competence? Or would you ask whether the statistical analysis was appropriate? As critical readers of research, you should automatically ask both questions. Now that we've distinguished these two broad concerns, let's focus first on construct validity, beginning with its definition. Construct validity is one of the most important concepts in behavioral, educational, psychological, and nursing research. Now let's begin with the word construct. What exactly is construct? A construct is an abstract concept. It is something that exists conceptually but cannot be observed directly. For example, you can actually see stress. Can you? Can you directly observe um, compassion? Can you physically measure resilience? Of course, the answer is no. These are all invisible concepts. We know they exist because we observe their indicators, but we cannot directly measure them like temperature, for instance, or blood pressure or body weight. That's why researchers must first define exactly what they mean by each construct before attempting to measure it. So construct validity refers to the extent to which a research study accurately measures the theoretical concept or the construct it intends to measure. In other words, are we really measuring what we think we're measuring? Let's look at some familiar nursing constructs. We have stress, anxiety, compassion, caring behavior, quality of life, patient satisfaction, clinical competence, burnout, health literacy, resilience. Notice something interesting. None of this can be measured directly. Instead, we develop questionnaires, observation checklists, rating scales, interviews, or performance assessments to represent these constructs. This diagram illustrates this diagram illustrates the process. So we begin with an abstract theoretical concept. Then we create an operational definition. Next, we identify the indicators or select an instrument. And then finally, we obtain measurable scores. The quality of those scores depends entirely on how well the instrument represents the original construct. So for instance, imagine that you want to measure clinical competence among, say, fourth-year nursing students. Could I simply count the number of books they borrowed from the library? Of course not. Okay, reading books may contribute to learning, but borrowing books is not the same as demonstrating competence in patient care. So one better approach would be an objective structured clinical examination, or OSCE, or a clinical performance checklist where students demonstrate actual clinical skills. The OSCE, or clinical checklist, is much closer to the construct of clinical competence than library usage. So remember this important statement. A construct is invisible. Researchers never measure constructs directly. Instead, they measure observable indicators that are assumed to represent those constructs. The entire goal of construct validity is to ensure that those indicators truly represent the underlying concept. Now, I'd like you to think of another construct commonly used in nursing research. Can anyone give an example? Okay. Take your time and think of an example of a construct that is commonly used in nursing research. Okay. Now ask yourself, how would you actually measure that construct? That is exactly what researchers must think about when designing a study. Now that we understand what a construct is, let's examine how researchers move from an abstract idea to an actual numerical data. Okay. One reason construct validity becomes difficult is that researchers do not measure constructs directly. Instead, measurement occurs through several important stages. Now, let's follow the pathway shown in the framework. We begin with the theoretical construct. This is simply the abstract idea we want to investigate. Now, suppose our construct is burnout among nurses. Now, at this stage, burnout is still only an idea. It has not yet been measured. So we move on now to the second box. The next step is the operational definition. Here, we answer the question, exactly what do we mean by burnout? So does burnout refer to emotional exhaustion, physical fatigue, loss of motivation, depersonalization, reduced professional accomplishment? Researchers must define this clearly because different studies may define burnout differently. Now, once the construct has been operationally defined, we select an appropriate measurement instrument. Okay, for burnout, we might use Maslach burnout inventory. For anxiety, we might use the Beck anxiety inventory. For resilience, for instance, we might use Connor-Davidson resilience scale. So for choosing the wrong instrument choosing the wrong instrument immediately weakens construct validity. Now, we move on now to the last box. Finally, participants complete the instrument and we obtain observed scores. So these are the numerical values that we analyze statistically. Notice something very important. By the time we reach the observed scores, we are already several steps removed from the original construct. Okay, so where can problems occur? Actually, problems can occur every single step. So it could be first box to second box and so on. Maybe the theoretical construct wasn't clearly defined. Maybe the operational definition was incomplete. Maybe the instrument measured only part of the construct, or maybe the instrument itself wasn't reliable, or perhaps the participants misunderstood the questionnaire. Any mismatch between these levels threatens construct validity. That is exactly why this warning is very important. Construct validity is threatened whenever there is a mismatch between the theoretical concept, its operational definition, the measurement instrument, and the observed scores. Think of this like diagnosing a patient. Suppose a patient complains of chest pain. The actual disease is the theoretical construct. So your assessment findings are the indicators. Laboratory tests and ECG are the measurement instruments. So the results you receive are the observed scores. If you choose the wrong diagnostic tests, you may arrive at a wrong diagnosis. So research works the same way. Good conclusions depend on choosing the right measurement process. Okay, so I want you to remember this simple sentence because it summarizes today's discussion very perfectly. Good statistics cannot fix poor measurement. So even the most sophisticated statistical analysis cannot compensate for measuring the wrong construct or using an inappropriate instrument. Measurement quality always comes before statistical analysis. Okay, so now that we understand how constructs are translated into measurable variables, we're ready to examine the specific threats that can weaken construct validity. These are common mistakes searchers make, often without realizing it, and each one has the potential to undermine the credibility of an entire study. So far, we've learned that construct validity is about ensuring that we are measuring the concept we intend to measure. The next logical question is, what causes construct validity to fail? So the answer is shown in this slide. Construct validity is threatened whenever our variables, interventions, or measurement tools fail to represent theoretical concept we want to study. Now think of it this way. Imagine you're trying to measure a patient's body temperature. If your thermometer is broken, the numbers you obtain won't represent the patient's actual temperature. No matter how carefully you record the readings or how advanced your statistical analysis is, your conclusions will still be wrong because the measurement itself is flawed. The same thing happens in research. Instead of measuring temperature, we often measure abstract concepts such as stress, anxiety, resilience, or clinical competence. If your instruments fail to represent those concepts accurately, then every conclusion that follows becomes questionable. Now, look at the diagram on the right. Notice that construct validity can be threatened from several directions. Some threats arise because the measurement itself is weak. Others occur because researchers fail to define the construct clearly. Sometimes the intervention does not truly represent what it claims to be. In other cases, participant behavior or researcher behavior unintentionally influences the results. We'll discuss each of these threats individually. So fortunately, once we recognize these threats, many of them can be prevented through careful planning. So remember this very important principle. Construct validity, the problems with construct validity begin long before statistical analysis. Let me say that again. Construct validity problems begin long before statistical analysis. So they begin during the design phase of the study. Now, I'd like you to think for a moment. Suppose you were conducting a research on compassion among nurses. What kinds of mistakes could cause you to measure something other than compassion? Let's pause for a while and then you think about different mistakes that could cause you to measure something other than compassion. Okay. After you think about those answers, Some of those ideas are exactly the threats we will be discussing. And you try to pause and try to think about what your answers are, and later on we'll try to discuss different threats and try to relate which of those answers that you've made actually pertain to the different tests that we will be discussing. Let's begin with one of the most common mistakes made by novice researchers. Now, I'd like everyone to imagine that you're reading a research article and the title says, Stress Among Nursing Students. Stress among nursing students. Now, let me ask you something. What exactly does the word stress mean? Take a few seconds to think about it. Okay. Some of you may think about examinations. Others may think about clinical duty. Some may think about financial difficulties. Others may think about family responsibilities. Okay, notice something interesting. Everyone interpreted the same word differently. That is exactly the problem. Inadequate explication of constructs occur when researchers fail to clearly explain what they mean by the construct before attempting to measure it. Without a clear conceptual definition, participants and sometimes even researchers interpret the construct differently. So let's examine our nursing example. The study claims to investigate stress among nursing students. But what kind of stress? Psychological stress, academic stress, physical stress, financial stress, emotional stress. Each one represents a different experience. If participants answer based on different interpretations, the resulting scores become inconsistent. One student may answer while thinking about examinations. Another may answer while thinking about tuition fees. Another may answer while thinking about difficult clinical instructors. Although everyone completes the same questionnaires, although everyone completes the same questionnaire, they are actually answering different questions in their minds. This weakens construct validity because the construct itself was never clearly defined. This is why literature review is much more than simply collecting references. One important purpose of reviewing previous studies is to discover how other researchers have conceptualized the construct. Then we develop a conceptual definition grounded in theory. For example, instead of simply saying stress, we might define it as academic stress refers to psychological strain experienced by nursing students resulting from examinations, assignments, and academic workload. Notice how much clearer that definition becomes. If you were studying resilience among nurses, what definition of resilience would you use? Would everyone define resilience in exactly the same way? Okay. Will you define resilience just the same way as your classmate will define resilience? Probably not. That's why researchers must define constructs before measuring them. Once we've clearly defined the construct conceptually, our next challenge is translating that concept into something that we can actually measure. So translating a concept into something that is measurable. Now let's move one step further. Suppose we've already agreed on what, for instance, in terms of clinical competence, we've agreed on what clinical competence means. Uh, Another question immediately follows. How are we going to measure it? And now this brings us to the operational definitions. Remember, the conceptual definition tells us what construct means. An operational definition tells us how we are going to measure it. Okay? A conceptual definition tells us what a construct means. And an operational definition tells us how we are going to measure it. So unfortunately, these two do not always match. Let's examine the example shown on the slide. The construct now is clinical competence. Now, imagine that a researcher decides to measure clinical competence by counting the number of books borrowed from the library. But before borrowing uh, more books automatically make someone, or does borrowing books automatically make someone clinical competent? Do you think? Of course not. Some students borrow many books but never read them. Others rarely borrow books because they use electronic sources, for instance, while others read borrowed books but struggle to perform procedures during clinical duty. Clearly, library usage is not a valid operational definition of clinical competence. The operational definition fails to represent the construct. So, how should clinical competence now be measured? Notice the example on the right. Objective Structured Clinical Examination, or OSCE, skills checklists, clinical performance evaluations, simulation assessments. These measures or methods actually observe students performing nursing skills. They are much closer to the construct we want to measure. So think of this as again, a diagnosing, an instance of diagnosing hypertension. Now, would you diagnose hypertension simply by asking, do you feel like your blood pressure is high today? You don't do that. Instead, you use a calibrated sphygmomanometer because it directly measures blood pressure. So research works exactly the same way. Choose an important or an instrument that actually measures the construct. Now, I want you to remember this sentence because you'll encounter this repeatedly throughout your research career. A good operational definition transforms an abstract idea into observable and measurable indicators. This is the landmark of a good research. Now, I'd like you to work with the person or with your classmate, and you try to pause this video for a while. You have to choose one construct, perhaps resilience, empathy, compassion, or leadership. Discuss one poor operational definition and one better operational definition. You can pause this video for a while, and then you may discuss this with your classmate. Okay, so far we've discussed two important threats. First, researchers may fail to define the construct clearly. Second, they may define it well, but measure it poorly. Next, we will examine another common problem, construct underrepresentation. So, where researchers measure only part of the construct instead of the whole concept. So far we've discussed two important threats to construct validity. First, researchers may fail to define the construct clearly. Second, even if the construct is clearly defined, they may choose an operational definition that does not adequately represent it. Now, let's examine another subtle but very common problem called construct underrepresentation. Now, I'd like you to imagine that you're performing a complete physical assessment of a patient. Suppose your clinical instructor asks, "How is your patient doing?" You reply, "The patient's temperature is normal, so the patient is healthy." Would that be an acceptable conclusion? Of course not. A complete assessment includes vital signs, physical examination, patient history, laboratory findings, and many other components. Now, looking at only one piece of information gives us an incomplete picture. The same principle applies in research. Many constructs that we study in nursing are multidimensional. They consist of several related but distinct components. Construct underrepresentation occurs when an instrument measures only one or a few of those components while ignoring the rest. Now let's use burnout as an example. Okay? Burnout is not a single feeling. According to the widely accepted Maslach burnout framework, burnout consists of three major dimensions: emotional exhaustion, depersonalization, reduced personal accomplishment. Okay? So each dimension contributes to the overall experience of burnout. Now, imagine that a researcher develops a questionnaire containing only items about emotional exhaustion. Questions might ask, do you feel emotionally drained after work? Or do you feel exhausted at the end of your shift? These questions certainly measure emotional exhaustion, but what about depersonalization? What about reduced personal accomplishment? Those dimensions are completely missing. Okay, the instruments measure only one third of the construct because one of the three components of the construct. So as a result, the construct is underrepresented. Why does this matter, or why is this a problem? Because researchers may underestimate or misinterpret the phenomenon they're studying. Now, consider two nurses, for instance. You have two nurses. Both experience burnout. The first nurse feels emotionally exhausted. The second nurse doesn't feel exhausted, but has become detached from patients and feels ineffective in providing care. Now, if your questionnaire measures only emotional exhaustion, we may incorrectly conclude that the second nurse is not experiencing burnout. In reality, the instrument simply failed to measure the other dimension. So this issue isn't limited to burnout. Think about other nursing constructs. Clinical competence includes knowledge, psychomotor skills, communication, clinical reasoning, professionalism, and ethical decision making. Quality of life, for instance, includes physical, psychological, social, environmental domains. Health literacy, for instance, it involves obtaining, understanding, evaluating, and applying health information. So whenever researchers measure only one component of a multidimensional construct underrepresentation occurs. Okay? Construct underrepresentation occurs. So as beginning researchers, many students create questionnaires by writing only 5 or 6 questions that seem related to the topic. But a good instrument isn't simply a list of related questions. It should represent the entire domain of the construct. That's why instrument development requires extensive literature review, expert consultation, pilot testing, and psychometric evaluation. Now, I'd like you to think about resilience. Okay, resilience. What dimensions do you think resilience includes? Could resilience be measured with only one question? What do you think? Okay. The more complex the construct, the more comprehensive our measurement should be. Okay, you have to take note of this. A construct cannot be represented only one of its dimensions. Comprehensive measurement produces valid conclusions. So construct underrepresentation occurs when we measure too little. The next threat that we'll be discussing is almost the opposite. Sometimes our measurements include things they were never supposed to measure in the first place. Now, let's consider another situation. Suppose your instructor wants to evaluate your clinical reasoning. Instead of observing you care for the patient, the instructor gives you a written examination filled with highly technical English vocabulary. Now, imagine that one student understands clinical reasoning very well, but struggles with English. Another student has an excellent English skills, but average clinical reasoning. Who probably would score higher? What do you think? Okay, perhaps the student with stronger English, not necessarily the one with better clinical reasoning. This illustrates construct irrelevant variance. Construct irrelevant variance. The construct irrelevant variance occurs when scores are influenced by factors that have nothing to do with construct being measured. Now, instead of measuring clinical reasoning, for instance, the examination begins measuring English proficiency. So let's carefully look at the nursing example. The research aims to measure clinical reasoning. However, students complete an examination requiring advanced English proficiency. Now, if students misunderstand the language, their scores decrease. Does that mean they lack clinical reasoning? Not necessarily. The problem lies in the instrument. Language ability has contaminated the measurement. This happens more often than you might think. Suppose you're measuring medication calculation skills. If the questions contain unnecessarily complicated reading passages, students' reading ability may influence the results. Suppose you're measuring patient satisfaction. If older adults cannot understand the questionnaire because of poor wording, literacy, not satisfaction, affects their responses. Suppose you're measuring anxiety. If the questionnaire is extremely long and exhausting, fatigue may influence responses more than anxiety itself. So, how can researchers minimize construct irrelevant variance? First, use validated instruments whenever possible. Second, ensure that language matches the participant's reading level. Third, pilot test the questionnaire. Identify possible extraneous influences before collecting data. And always ask yourself, is there anything besides my construct that could influence these scores? One hallmark of an excellent researcher uh, is that one hallmark of excellent researchers is that they think about sources of error before they begin their study. Poor researchers blame unexpected results after the study is finished. Good researchers, on the other hand, they anticipate problems and design studies that minimize them. Now, can anyone think of another factor that might influence test scores beside the construct itself? What do you think? Okay. Some of you might answer fatigue, stress, poor lighting, distractions, language, hearing impairment, and others. Now, those are examples of possible construct irrelevant factors. You have to take note that scores should vary because of differences in the construct, not because of unrelated influences. Okay. So far, we've discussed problems related to measurement. Now let's shift our attention to the intervention itself. Okay, so now imagine you're evaluating the effectiveness of simulation-based education. One researcher conducts a complete simulation program consisting of pre-briefing, simulation, debriefing, repeated practice, and guided reflection. Another researcher conducts only one 20-minute simulation exercise and calls it simulation-based education. Are these really the same intervention? Do you think? Well, not at all. This is called mono-operation bias. Mono-operation bias. So mono-operation bias occurs when researchers use only one version or one component of a complex intervention. The intervention becomes an incomplete representation of what it actually is. Now notice this nursing example. The intervention consists of one 20-minute simulation activity, but simulation-based learning is much more than simply performing one scenario. High-quality simulation usually includes several stages. First comes the pre-briefing. Students receive orientation, objectives, and expectations. Next comes the simulation itself. Then comes the briefing. The briefing is often considered the most important part because students analyze their decisions and receive feedback. Many simulation programs also include repeated practice and structured reflection. Each component contributes to learning. This is similar to evaluating, for instance, CPR training. Suppose one researcher teaches only chest compressions and concludes that CPR education is ineffective. Would that be a fair conclusion? Of course not. The CPR education includes airway management, uh, ventilation, teamwork, rhythm recognition, communication, and repeated practice. So evaluating only one component provides an incomplete picture. Now, if researchers use only one version of an intervention, the results may not represent the intervention as it is normally delivered in clinical practice. Consequently, other researchers cannot confidently compare findings across studies. So when reading intervention studies, you have to always ask, did the researchers evaluate the complete intervention or only one part of it? This question is specifically important in nursing education, in health promotion, in counseling, and behavioral interventions. Now, can anyone think of another nursing intervention that consists of multiple components? Okay, some of you might think about discharge planning, diabetes education, infection prevention bundles, breastfeeding education, and others. Many interventions are complex and should not be reduced to one activity. The complex interventions must be represented by all of their essential components, and not just one. So mono operation bias concerns the intervention. Okay. Our next threat concerns the method that we use to measure it. Okay. Imagine that I ask each of you one simple question. How competent are you as a nursing student? Do you think everyone would answer accurately? Probably not. Some students are very confident and overestimate their abilities. Others are very humble and underestimate themselves. Some may answer based on yesterday's performance, or others may answer based on how they feel today. This illustrates another important threat known as mono method bias. Mono method bias. It occurs when researchers rely on only one method of measuring a construct. Because every measurement method has strengths and weaknesses, relying on only one increases the risk of systematic error. Now let's take a look at this example. Um, in this example, the construct is clinical competence. The researcher measures competence using only a self-assessment questionnaire. Self-assessment certainly provides useful information. Students understand their own confidence, learning needs, and perceptions. However, self-assessment also has limitations. Some students overestimate their competence, others underestimate it. So consequently, self-reported competence may differ substantially from actual uh, clinical performance. So how can researchers improve measurement? The answer is shown on the right side of the slide. So instead of relying on one method, we use triangulation. Triangulation means collecting information from multiple sources or methods. For clinical competence, we might combine uh, objective structured clinical examination or OSCEs, or we have the performance checklists, instructor evaluations, peer evaluations, self-assessments. Okay? So this method provides a different perspective. Together, when put them together, they produce a more balanced and comprehensive assessment. So you have to think about it, or think about patient assessment, for instance. Would you diagnose pneumonia using only the patient's temperature? Would you know if a person has pneumonia by only looking at the patient's temperature? Of course, you have to combine patient history, physical examination, chest auscultation, chest radiography, oxygen saturation, and laboratory findings. Research follows the same principle. The more appropriate sources of evidence we combine, the stronger our conclusions become. The idea is especially important in qualitative and mixed methods research. When different methods point toward the same conclusion, our confidence in the findings increases. That's one reason triangulation is considered a hallmark of rigorous research. Now let's apply this concept. Suppose your thesis aims to measure patient satisfaction with nursing care. Besides a questionnaire, what other methods could you use? Okay, for some of you might think about interviews, focus group discussions, direct observation, complaint records, suggestion boxes, or patient narratives. Those are all examples of triangulation. If you do them, or more than just one way for you to um, evaluate patient satisfaction. So no single measurement method is perfect. Using multiple complementary methods provides a more accurate representation of the construct and strengthens construct validity. Okay, so now we have discussed six major threats to construct validity. The next four threats shift our attention from the measurement instrument to human behavior. Even when researchers use excellent instruments, participants and researchers themselves can unintentionally introduce bias into a study. So in the next session, we will explore social desirability bias, the Hawthorne effect, the experimental expectancy effect, and so on. These threats that remind us that research involves people, and people do not always behave naturally when they know they are being studied. Let's start now with the next threat pertaining to or arising from participants. And this threat is social desirability bias. So far, the threats we've discussed have focused largely on the measurement instrument. However, if we develop an excellent questionnaire, another important source of error remains, which are the participants themselves. So let's begin with a simple question. If I ask everyone in this classroom, do you always practice proper hand washing before and after every patient contact? Do you always practice proper hand washing before and after every patient contact? Of course, many of you would answer always. Okay, now let me ask a different question. Do you think everyone who answered always actually practices hand hygiene perfectly every single time? Okay, well, probably now the answer is no. So this difference between what people say and what they actually do illustrates social desirability bias. Okay, social desirability bias occurs when participants provide answers that they believe are socially acceptable or professionally desirable rather than answers that honestly reflect their behavior, their thoughts, or their feelings. Now, let's look at the nursing example on the slide. The researcher asks nurses, do you always wash your hands before patient contact? Many nurses respond, yes, always. Why? Not necessarily because they always comply, but because they know hand washing is the expected professional behavior. However, when infection control officers conduct direct observations or hand hygiene audits, compliance rates are often considerably low. This tells us that self-reported behavior may not actually accurately reflect actual practice. So why does this happen? Notice the reasons listed on the slide. Participants may want to please the researcher. They may feel criticism or negative judgment. They may want to appear ethical, competent, or professional. This is especially common in nursing because our profession emphasizes caring, ethics, and accountability. So as a result, respondents often answer according to the image they want to project rather than their actual behavior. Consider these research examples or research questions. Do you always obtain for consent before performing procedures? Do you always maintain patient confidentiality? Do you always report medication errors immediately? These questions involve socially desirable behaviors. Participants may hesitate to admit mistakes even when anonymity is assured. So how can researchers minimize this threat? First, of course, you have to ensure anonymity and confidentiality. because participants are generally more honest when they know their identity cannot be linked to their responses. The next thing is you use neutral or non-judgmental wording. Instead of asking, "Do you always follow infection control protocols?" You might ask, "How frequently do you perform hygiene before patient contact?" Okay. So third, whenever possible, combine self-reports with objective measures such as direct observation, audit records, or electronic monitoring. And finally, build rapport and trust so participants feel safe providing honest responses. Okay, as nurse researchers, remember this important principle. People rarely lie because they want to deceive the researcher. Okay? People rarely lie because they want to deceive the researcher. More often, they answer in ways that preserve their self-image or conform to professional expectations. So understanding human psychology helps us design better research. Now, can you think of another health behavior that people often over-report? Okay. What do you think? Some of you might answer exercise, okay? Healthy eating, medication adherence, smoking cessation, alcohol intake, or the use of seat belts. Okay? These are all behaviors that are susceptible to social desirability bias. So whenever researchers rely solely on self-reported behaviors involving socially valued actions, they should always consider the possibility of social desirability bias. Okay? Now, let's examine another situation where people change their behavior not because they want to look good, but simply because they know someone is watching them. I know this is very familiar with most of you. Okay, I'd like you to imagine that your clinical instructor suddenly walks into your ward while you are administering medications. Okay, what happens almost immediately? Most students become more careful. They double check the patient's identification. You review the medication order again. You slow down and carefully follow every step. Okay, why? Because you know you're being observed. This is called the Hawthorne effect. The Hawthorne effect occurs when participants change their behavior simply because they know they are being observed, evaluated, or studied. Importantly, the behavior because of the observation itself, not necessarily because of the intervention, they change their behavior. So notice the example on the slide. Researchers observe nurses during medication administration. Under ordinary circumstances, medication administration accuracy may average at around 65%. However, during the direct observation, nurses become more cautious. They verify patient identity more carefully. They check medication labels repeatedly. As a result, observed accuracy increases dramatically. Now, does this necessarily mean nursing practice has improved? Not necessarily. The improvement occurred because participants knew they were being watched. This effect occurs in many healthcare settings, like health workers improve hand hygiene during audits, students perform better during observed clinical examinations. Patients become more compliant when researchers visit their homes. Healthcare providers, for instance, they document more thoroughly during accreditation visits. The behavior changes temporarily because observation influences performance. So, how can researchers minimize this threat? One strategy is prolonged engagement. When observers spend enough time in the clinical setting, participants gradually become accustomed to their presence and return to their usual behavior. So researchers may also use unobtrusive observation methods, random observation schedules, or collecting data during routine practice over extended periods. So combining observations with chart reviews, for instance, or electronic records also helps validate the findings. Okay, as researchers, remember that what people do while being watched is not always what they do every day. So our goal is measure routine clinical practice, to measure routine clinical practice, not performance during the inspection. So can anyone think of situations outside research where the Hawthorne effect occurs? Examples or scenarios outside the research where Hawthorne effect occurs. What do you think? So some of you might think about the installation of CCTV cameras. If you know you're on CCTV, you might change your behavior. Traffic police presence. If there is a police around, you would change your behavior. Workplace supervision or classroom observations. Uh, Human behavior changes when people know they are being observed or they are being watched. So observation itself can become an intervention. So researchers must distinguish genuine behavioral change from temporary change caused by being observed. Okay. So in the Hawthorne effect, participants influence themselves because they know they're being watched. Our next threat involves the researcher unintentionally influencing the participant. So imagine that you are comparing two teaching strategies. Deep inside, you already believe that strategy A is superior. Even if you try to remain objective, what might happen? You're comparing two teaching strategies. You're a researcher. You're comparing two teaching strategies. You're also an educator. Now, deep inside, you already believe that strategy A is superior. Even though if you're objective, you may still smile more when teaching strategy A. You may encourage those students more often. You may provide more detailed explanations. You may spend a little extra time answering their questions, or you may not even realize you're doing it. This is the experimenter expectancy effect. This effect occurs when researchers, the expectations of researchers unconsciously influence participants or the study procedure. So ultimately, it affects their results. In other words, the researcher becomes a part of the intervention. So let's take a look at the example. In this study, faculty members believe teaching strategy A is better. They believe that strategy A is better. Now, without realizing it, they provide more encouragement, more positive feedback, and more enthusiasm to students receiving strategy A. Students become more motivated. Consequently, their performance improves. But here's the important question. Did students improve because strategy A is truly superior, or because the instructor treated them differently? Okay, if the researcher behavior influenced the outcome, construct validity is threatened. Okay, so this phenomenon occurs in many healthcare studies. A researcher may unconsciously spend more time with patients in the intervention group, or a clinical instructor may provide more coaching to one group, or an evaluation may score performance checklists more generously because they expect one intervention to work. Or even a subtle facial expression or tone of voice can influence participant responses, and this often are unconscious on the part of the researchers. How do we prevent expectancy effects? Researchers use several strategies to minimize this bias. So use standardized procedures, use identical instructions for all groups, blind assessors whenever possible so evaluators do not know which intervention participants receive, and provide training to data collectors. Use objective outcome measures such as validated tests or physiological indicators whenever possible. Now, this threat reminds us that good researchers are not only knowledgeable, they are also self-aware. Now, being aware of your own expectations helps us. Being aware of our own expectations helps us prevent those expectations from influencing participants. Suppose, for instance, you are evaluating students during skills performance. Would it matter if you already knew which students attended an expensive review program, for instance? Mm. Could that knowledge influence your rating? And that's exactly why blinded assessment is considered a hallmark of rigorous research. If you think your your knowledge, initial knowledge about the participants could affect how you rate them, then perhaps blinded assessment is carefully considered. So researchers should strive to influence only the intervention, not the participants, through their own expectations. So far, we've seen how researchers can unintentionally influence participants. Now we'll examine what happens when participants begin trying to help the researcher. Okay. So our final threat is called demand characteristics, and it's one of the most fascinating aspects of research psychology. Imagine you volunteer for a research study evaluating mindfulness training among nursing students. During orientation, the researcher enthusiastically explains that mindfulness is expected to reduce stress. Now, as a participant, what might you begin thinking? Okay, perhaps the researchers expect my stress levels to improve. Maybe I should report lower stress after the intervention so the study succeeds. Now, this is demand characteristics. Demand characteristics occurs when participants become aware of the study's purpose and adjust their responses or behavior based on what they believe researchers expect. Yeah, that's the reason why it's demand characteristics. Now, let's take a look at the example. Notice how the process unfolds. Participants notice clues about the study, perhaps from the consent form, perhaps from the title, perhaps from conversations with researchers. They infer the expected outcome. So then they adjust their responses accordingly. The resulting data then reflect participants' expectations, not necessarily the true effect of the intervention. Okay, this occurs frequently in behavioral research. Participants receiving stress management training report feeling less stressed because they believe they should. Patients receiving counseling report improvement because they want to satisfy researchers. Students evaluating a new strategy or a new teaching strategy report higher satisfaction because they know faculty developed the program. So how do you reduce demand characteristics? Researchers minimize this threat by providing only the information necessary for informed consent, avoiding leading descriptions or of expected outcomes, using neutral study titles when ethically appropriate, or incorporating control or placebo groups, maintaining anonymity and debriefing participants after data collection. So the goal is never to deceive participants unnecessarily, but to prevent expectations from shaping responses. So ethical research requires balancing two responsibilities. So on the other hand, we have participants deserve enough information to provide consent. At the same time, researchers should also avoid unnecessarily revealing hypotheses in ways that could bias participant behavior. So this balance requires careful planning and ethical judgment. So imagine you're conducting a research on sleep hygiene among nursing students. What study title would reveal the hypothesis? And what title might be more neutral? You think about several examples when you do sleep hygiene or research on sleep hygiene. Okay, you you can pause this video for a while, and you may notice how wording alone can influence participant expectations. Okay, so now we've completed all the 10 major threats to construct validity, and you notice that these threats originated from different sources. Some resulted from poorly defined constructs. Others arose from weak measurement instruments. Still others came from participants' behavior or researchers' own expectations. Now, despite their differences, they are all they all share one consequence. That is, they prevent researchers from accurately measuring the construct they intend to study. So now that we have explored these threats to measurement quality, we'll shift our attention to the second major topic. But uh, let's uh, let's take a look at how we can improve first how we address these construct validity issues or threats. Okay, as you can see, there are different threats to construct validity, and this at this point you might be thinking there are so many ways construct validity can go wrong. How can researchers avoid all of these threats? Now, the good news is that most threats to construct validity can be prevented during the planning stage of a research study. So, in other words, a good research doesn't happen by accident, it is carefully designed. So, this slide summarizes 8 practical strategies that every researcher should remember. Now, think of this as your researcher's checklist before collecting data. Okay, the first one is clearly defined constructs. We've mentioned this over and over in our past discussions. Everything begins with a clear understanding of what you want to measure. So you ask yourself, what exactly do I mean by this construct? If your study is about resilience, don't simply write resilience in your proposal. Define it conceptually, identify its dimensions, and develop an operational definition that truly reflect those dimensions. Remember our first threat, inadequate explication of constructs. A poorly defined construct leads to confusion throughout the entire study. The second one is use established theories. This second recommendation is to ground your study on established theories. Why is the theory important? Oh, because theories tell us what a construct actually includes. So, for example, if you're studying burnout, don't create your own definition based on solely personal opinion. Use recognized theoretical frameworks such as the Maslach burnout theory. Theories provide a strong scientific foundation and help ensure that researchers across different studies are measuring the same underlying concept. The third one is to employ validated instruments. Now, whenever possible, use instruments that have already been tested for validity and reliability. So remember, an instrument is more than just a questionnaire. A good instrument has undergone years of development, expert review, pilot testing, and psychometric evaluation. So before using any instrument, you ask yourself, has it been validated? Is it reliable? Has it been used successfully among populations similar to mine? If you adopt existing questionnaire, for example, translating it into Filipino, you should also validate the adapted version. Okay. The fourth one is pilot test newly developed questionnaire. So suppose you create your own questionnaire. Never use it immediately for your main study. Instead, conduct a pilot test. So a pilot study allows you to you would identify unclear questions, ambiguous wording, missing response options, and logical problems before collecting data from your actual participants. Think of it this way. Hospitals don't immediately introduce a new clinical protocol across the entire institution. Often they pilot test it first. So research should follow the same principle. Okay, the fifth one is to train data collectors. So even the best questionnaire can produce poor data if data collectors are not properly trained. So imagine that 3 research assistants administer the same questionnaire differently. One explains every question, the another gives additional examples, and then the third provides almost no instructions. Participants are no longer receiving the same measurement. Training ensures consistency. So you have to spend some time training your data collectors. Everyone should follow the same procedures, provide the same instructions, and understand exactly what each construct represents. This reduces observer bias and improves data quality. Okay, and then the sixth one is to standardize intervention. Let's consider intervention study. Suppose you're evaluating a diabetes self-management program. Would it be acceptable if one facilitator spends 30 minutes teaching while another spends 2 hours? Or if one facilitator uses videos while another uses only lectures? Okay, the intervention itself must be delivered consistently. Researchers often use manuals. They use protocols or checklists to ensure every participant receives essentially the same intervention. So standardization strengthens construct validity because differences in outcomes are more likely due to the intervention, not differences in how it was delivered. The seventh one is to use multiple methods of measurement or triangulation. So this recommendation should sound familiar because we already discussed monomethod bias. So no single method captures an entire construct perfectly. Therefore, researchers often combine multiple methods. So for instance, measure clinical competence, we might use a performance checklist, instructor evaluations, peer evaluation, self-assessment. So when different methods lead to similar conclusions, your confidence in the findings increases. So this approach is called triangulation, as we mentioned, and it's one of the hallmarks of high quality research. And then the last one is um, blind participants to the study hypothesis when feasible. So our final recommendation addresses the last threats we've discussed, so demand characteristics and response bias. So if participants know exactly what researchers expect, they may consciously or unconsciously adjust their responses. Whenever ethically appropriate, the researchers should avoid revealing the expected outcomes of the study. Notice that this does not mean deceiving participants. Participants must always receive sufficient information to provide informed consent. However, researchers should avoid unnecessarily revealing the study hypothesis in ways that influence participants' behavior. Okay? The goal is to collect authentic responses, not responses designed to please the researcher. Now, let's take a look at the bottom of the slide. Just this one. Notice a consequence. When researchers accurately measure the construct, they strengthen internal validity. Stronger validity produces stronger evidence. Stronger evidence supports better clinical decisions, and ultimately better research leads to better patient care. That's why construct validity isn't just a methodological concern. It directly affects evidence-based nursing practice. So before we move on to the next topic, I'd like to leave you with one important thought. Um, as future nurses, you'll spend much of your careers reading research articles. I hope you will still continue to read research articles even after you complete your academic requirement. Now, whenever you read a study, don't immediately ask, was the result statistically significant? Huh? Instead, first ask, did the researchers truly measure what they claim to measure? Because even the most sophisticated statistical analysis, they cannot rescue a study that measures the wrong construct. So, in research, measurement comes before mathematics. So if the measurement is flawed, the conclusions will also be flawed. Okay. We have now completed the discussion for construct validity, from its definition to conceptual framework to the 10 major threats and practical strategies for improving it. Now, the common theme throughout this section has been measurement quality, ensuring that our instruments, interventions, and procedures truly represent the concepts we intend to study. So the next major question is this: even if we measure the right construct correctly, how do we know that our statistical analysis justify the conclusions we make? That question now leads us to our second major topic, which is statistical conclusion validity. So where our focus now shifts from how we measure or how we measure to how we analyze and interpret research data.